started. My name is Katie Knight, and welcome to the 5-part series using telementoring to optimize quality of care and quality of life for patients with metastatic kidney cancer. We call it Toqq-Rcc. Again, like I said, my name is Katie. I'm a member of the research staff at the University of Kansas Cancer Center within the Division of Medical Oncology. And I've been fortunate enough to work on this project with Drs. Klemp and Wolf Birchfield. Dr. Birchfield is an assistant professor and medical oncologist with the University of Kansas Medical Center, and her specialties include genitourinary oncology and hospice and palliative medicine. Dr. Klemp is a professor with the University of Kansas Medical Center, and her clinical and research interests include cancer survivorship, cancer risk and genetic counseling, and of course, improving access to point of care service through telementoring. It's really great to be here with you guys today. Libby, would you like to introduce Dr. Doolittle for us? You're muted, Libby.
Yes, I'm so pleased to be here with everybody and to introduce wonderful Dr. Doolittle, a colleague of mine here at KU. So Dr. Doolittle is a medical oncologist and palliative care physician as well, and practices primarily medical oncology, specializing in melanoma. He's been a part of KU as an early adopter of immunotherapy and certainly continues to use that on a frequent basis. He also has a role here with us at the Masonic Cancer Alliance. And we are so grateful to have him here with us as in his leadership role, both in his clinical role as well as his leadership role in the Masonic Cancer Alliance. And Dr. Doolittle also has a role here with the University of Kansas Medical School and is a dedicated educator. So he's a triple threat when it comes to academic medicine. So thank you for being here with us.
Very much so. So yes, thank you, Dr. Doolittle. Thank you, Libby. Appreciate that. We will go through a few slides here pretty quickly and then do some introductions. We've got a nice group here already. Happy to see that. So this is a review of our agenda for today. If you haven't already, please sign in for this session by putting your name and organization in the chat box. Just a reminder that after each session, we will put the slides and recording of the didactic and tools referenced in the session. We'll add those to the Masonic Cancer Alliance website. It's masoniccanceralliance.org, and it's under the telementoring page. I believe we're going to stop here for just a second and do our quick introductions. I'll just call your name and we'll go through pretty quickly. Let's see here. Tracy, let's start with you real quick.
Good afternoon, everyone. I'm Tracy McCarty with the Masonic Cancer Alliance, and I'm part of the Cancer Echo team.
Great, thanks, Tracy. Let's see, Carol.
Hi, I'm Carol Bush, and I'm excited to be here. I know many of you. I'm a longtime oncology nurse activist, and now I'm with the palliative care team as a case manager here with Ascension Via Christi.
Awesome. Glad you're here today, Carol. Let's see. I don't know what the name is, but the name on the Zoom box is DeWitt Kopp, DeWitt Kopp. You want to introduce yourself for us? Oh, Denise, you're Denise. Denise, we're glad you're here today.
Hi, I'm glad to be here. Thank you.
I didn't give you enough time. I apologize. I know we got to figure all these things out, don't we? Amy Gibson BB.
Hello, can you hear me?
We can, yes, thank you.
All right.
Amy, who are you with? Let's see, ABC Pittsburgh, and you're an APRN. Wonderful. Oh, and RadOnc. Okay, wonderful. Good. We're glad you're here with us today, Amy.
Thank you.
Annie, would you like to say hi?
Sure would. I'm Annie Rogers, and I'm with our outpatient palliative care group at the Westwood Cancer Center.
Awesome. Welcome.
I have the pleasure of working alongside Dr. Wolf Birchfield and Dr. Sinclair that's on here.
Awesome. So friends, you have friends. Speaking of Dr. Sinclair, how are you today?
I'm doing good. Good to see you, Katie. I'm an outpatient palliative care doctor at KU Cancer Center, and always appreciate learning from these sessions.
Me too. Hi, Mary Ellen. How are you?
I'm good, thank you. I'm Mary Ellen Potts. I'm faculty with the School of Nursing here at KU, and I do research in palliative care and cancer care.
Awesome. Thank you. Julie, would you like to say hi, or can you say hi?
Hello.
Hi. Julie, you're with Olathe Health. What is it that you do down there?
I'm a nurse navigator.
Awesome. Thank you so much for joining us today. We're glad you're here.
Thanks.
Hi, Vicki. How are you?
I think she said in the chat that she doesn't have a microphone today.
Okay. Thanks for paying attention to that for me. Well, we're happy you're here, Vicki. Hopefully you can hear us. Let's see. Let's say hi to Grace. Grace Martin.
I think Grace Martin and Kathy Davis may not have a microphone today, just based on their where they appear in the participant box.
Gotcha.
But Grace Martin is an oncology pharmacist here, Doctor of Pharmacy at University of Kansas, and Kathy Davis is an oncology clinical nurse coordinator here, and she works in GU oncology with me.
Great.
And I think, isn't Grace one of the guest speakers for the upcoming Toqq-Rcc?
She will be. She is, yes.
Excellent.
Awesome.
Member of an esteemed minority.
Yes, we're so glad to have her coming up.
Absolutely. All right. Well, we're so happy you all are here today. And like I said, if you haven't put your name in the chat box, it's important to do. We need you to check in if you want to get those CEs. I'm going to run through the next few housekeeping slides a little quickly, but just remember, we do put the slides up on the NCA website for you to refer back to. This is our conflict of interest disclosure for you to review. And let's see, make sure I'm not missing anything. These are going to be, the next 3 slides will be the continuing education slides that will be important for you to get your CEs. One of the things that's a little bit new is that we do really need for your name to be in your Zoom box. And that is part of the way that they are basically taking attendance. So just FYI, and then of course, put your name in the chat box as well. This is the continuing education statement regarding the credits that can be earned. And if you're not interested or in need of CEs specifically, we do also offer certificates of attendance. This is the code that you'll need. If it's helpful, you can take a quick photo of this slide. If you need any of this information afterwards too, you're welcome to shoot me an email. 93 SORN is the activity code for today, and that due date is Thursday, June 17th at 5 p.m. And Mary Beth Warren with AHEC always wants me to remind you that that is a firm deadline. Our funding source, we have been so fortunate to be have this project funded by a Pfizer independent grant for learning and change. And then of course, none of this is possible without the support from the University of Kansas Cancer Center and of course the Masonic Cancer Alliance. By participating, you are agreeing to be or consenting to be recorded. We do record these for QI and then of course as part of our enduring materials. We are all Zoom experts at this point, or at least we're getting there. I think one of the most important things is just to keep yourself muted when you're not speaking and engage. If you can put your camera on, do it. We love to see your faces. We do love to do polling questions. We usually have 1 or 2 during every session. Basically, a little window will pop up and you make your choice, and then we get to see the results in real time. Okay, I think this is my last slide before we get started. This is just a reminder that we do discuss cases and the images are not actual patients, they're just usable images. But the most important thing is that if you have any patients to discuss yourself or would like to get input on, just please to remember to not share any patient identifiers. Okay, with that said, this is your learning objective for today, and I am quite certain that between Dr. Wolf Birchfield and Dr. Doolittle, you will meet this expectation. So with that said, I think I hand it over to Liz.
Based on her anemia of an intermediate risk, and so she was seen to have, she engages with her medical oncologist to decide what sort of treatment that she should start with, and she is receiving treatment in the current era where we have many really good first-line treatments to choose from. And so from there, she asks, what is immunotherapy like? She is a medical professional, and she has seen patients have cancer and has people in her personal life who've had cancer before. And she says, what should I expect? What are most people's experiences like when they're on immunotherapy, and what are all the things that are going to come the way? So, and I will comment that while we're talking about kidney cancer, because that's kind of the nature of this funding and this series, this case, the rest of the case will absolutely apply to any other cancer that we treat with immunotherapy for advanced disease. So just keep that in mind. While all of you may not see as much kidney cancer as I do, you probably see diseases that are managed in a really similar way. So on the next slide, so in thinking about the immunotherapy spectrum, Dr. Doolittle is here with us today and has graciously agreed to present some didactics about immunotherapy and toxicity and a few other topics. So I'm going to pass these slides over to him for a few, and then we'll get back to the case.
Great. Thanks, Dr. Birchfield, and thanks for the invitation to speak with you all this afternoon. Jennifer, Katie, Tracy, I really appreciate it. This is a topic that I'm very interested in, and just by way of a little bit of background, as Libby said, these drugs are used for a variety of different diseases, and she's an expert in kidney cancer, and my particular area of interest is melanoma. And the reason I'm so fascinated about these drugs is they were the first class of drug that showed improved survival in the treatment of melanoma. And they came out 10 years ago this last March. We had our first drug, and then the second, the anti-PD-1s, about a year later. So I was able to watch, and Christian will appreciate this, Libby will appreciate this. I really functioned much more as a palliative care physician until these agents came and truly changed the natural history of the disease. So it's been really gratifying to watch that and to be part of that. There are different categories for the immunotherapy. We have checkpoint inhibitors, which we're going to talk about today. And those are the relatively new agents. We had cytokines before, in particular for renal cell, high-dose IL-2, and we did have some activity with high-dose IL-2 in the kidney cancer range. Vaccines, and of course, most recently, CAR T-cell therapy. This whole field is, absolutely stunning when we look at the changes that have occurred in a very short time period. Can we have the next slide? Great. So to give some idea about the immune checkpoint inhibitors, they're molecules that help us maintain an immune balance. And we want immune cells to rev up and become activated to fight either an infection, or in our case, to fight a cancer. But when that's taken care of, then we want those same revved immune cells to tone it down. And that's where the immune checkpoints come into play. And if we didn't have this system, we'd all be running around with autoimmune diseases in which our immune systems would be attacking normal tissues. So this is a really critical, delicate balance between activation and deactivation in the well patient. There are other checkpoints that actually inhibit some of the molecules that and can be co-stimulatory to molecules. So there's a different range that we can look at in our treatment armamentarium for this group. We've known for a long time tumor cells can evade the innate immune surveillance, and it's almost stunning when you think about the mechanism, right? That a tumor cell really can develop this inhibitory molecule that will neutralize the activity of an immune cell or a lymphocyte. We've known that for quite some time, even over 100 years. The immune checkpoint inhibitors are monoclonal antibodies that block these co-inhibitory molecules and then allow for the immune cell to become active or unleash the cell-mediated immunity that they possess. All ICIs have the potential to create an unchecked immune environment. And with that, we can see autoimmune side effects, inflammatory side effects. And in fact, we infuse these drugs to patients, and it isn't the infusion that causes a reaction. This isn't chemotherapy. It's really, the side effects really come over days and weeks. and are related to what we want as cancer people, related to activated cells that we want them to fight the cancer, but unfortunately they fight normal tissues as well. So while clinical trials demonstrate patterns of immune-related adverse events, they are, some could be unpredictable, but some we'll learn you can expect, and you can expect over a specific time frame. I think it's very important to remember that there is no universal experience. Not everyone will get a side effect. Some patients will get more than one, and it's just upfront when educating a patient, it's critical that we let the patient know, we're going to give you a list of all these possibilities, all these different things that can happen, but none of them may happen to you, or several of them may. And in our effort to inform correctly, sometimes we give them a lot of information to try to process up front. Okay, the next slide, please. So the nature of the immune-related adverse events, they come in obviously different organs can be involved in different grades of toxicity. They can range from anywhere from 40 to 96%, just numbers of patients that are involved. They can be dependent upon the dose of the agent, the single agent itself versus a second, whether there's combination therapy. It could depend on the setting and the patient population, because there will be some populations that will be more sensitive than others. The incidence of grade 3-4 immune adverse events can range anywhere from 0 to 60%, but oftentimes we'll see a range anywhere from 20 to 55%. They're really frequent, and patients are going to experience it, and they need to have a lot of good information up front. We really want them to report to let us know if they're having side effects, and we also don't want them to be frightened by a side effect that they were not anticipating or didn't think was possible. The most common immune adverse events: fatigue, pruritus, rash, diarrhea, hypothyroidism. And again, these can be all grades 1 through 4. The most common grades 3 and 4 immune events are fatigue, diarrhea, rash, hypophysitis, pneumonitis, and hepatitis. Usually when I'm talking to a patient, we talk in terms of almost every organ system in the body can be affected in some way. Next slide, please. Okay, so I love this slide. The minute I looked at it, I loved it. I thought I wanted to enlarge it. I'm going to frame it. I'm taking it home. That's what happens to a crazy melanoma doc over years. This just gives us a great picture or pictorial of the different side effects that the immune agents can cause. And not only does it tell us the differences between an anti-PD-1 versus a CTLA-4 blocker, but it also gives us the relative frequency by the size of the circles that exist, and the relative severity based on how they're colored, right? So if you take the image to the left, the larger circles are the more frequent problems. That's how we have illustrated that particular side effect is more common. So colitis, peripheral neurologic disorders, anemia, problems with the skin can be quite frequent. But the thing I really like about the cartoon is that the peripheral neurologic disorder can be much more, the incidence can be much more in grades of 3 and 4. So it gives you that idea. Myocarditis can happen with any of these agents, okay? And that obviously that's severe. That's the bad news. The good news is the circle's small and the incidence of it isn't very, very common. So the other piece I like about this is they break it out between the different drugs, because I think the anti-CTLA-4 blocker, or Yervoy, has very similar side effect profile to the anti-PD-1s, but they tend to occur more frequently and they tend to be more severe. And certainly when you put the combination together, an anti-PD-1 with an anti-CTLA-4 blocker, the circles are bigger, there's more red. We'll just put it that way. In any event, this is really a great tool. And I'm not kidding when I want to have this down in clinic with me. I have a lot of learners in clinic. We have a team that that deals with these drugs every single clinic. So it's just a great tool. The other thing I think is really nice about it, I'm going on about this slide. I'll quit, I promise, to the organizers. He's spending too much time on this slide. I just think it's actually really good for us to as a team know that we're working at this the same way and giving these to patients so they have some idea of what to expect in terms of incidence and severity of side effects. Can we have the next slide? And what about the timing? I think this is really important too, because when patients are being treated, that first treatment is nerve-wracking. No matter how much we try to reassure, it's a nerve-wracking process. And I think the images that you see on this slide gives the patient some idea of when to expect the onset of some of these symptoms. Patients are really good at educating, right? They want to be educated, or will do a really good job of educating. But educating a patient and actually preparing them for what those side effects are going to be and when they're going to hit aren't always the same thing. I've had patients tell me, yeah, I was really well educated, but when the colitis started, I'm not sure I was really prepared for what that was going to be like, right? Or yeah, we spent hours Googling, and family, everybody was after, you spent an hour with us, we did. But in the end, when the symptoms started, it was a different experience, right? In any event, I like this slide because, again, it gives us all an idea of the timing when these things can occur. So the majority of grade 3-4 adverse events occur within 8 to 12 weeks, right? It's not like they take one dose and they're sick within a week. And I think we really need to tell patients, if you get sick, call us, but the odds are, if you're going to have one of these side effects, it's going to come over time. If you look at the graphs that have been shown, the yellow lists the timing when colitis most frequently hits in. And it tends to be within the first month and can stretch out over 2.5 months over time. I'm sorry. Yeah, the first month to 2.5 months. If you look at the blue, that's when endocrinopathies hit. And again, may not hit up to 6 weeks if we think of just the anti-PD-1s. And the table or the graph down in the lower left-hand corner actually has what happens with the combination, right? So in combining an anti-PD-1 with a CTLA-4 blocker, the immune therapy side effects that have to do with endocrine lesions can be initiated. We can start to see them early on. The same is true with just about any of the side effects. It's like the curves have shifted just a little bit to the left. And the other thing that's important is that the toxicity grade is higher. When you look at the three graphs and you look at the combination, the toxicity is higher with the combination therapy. I actually think this would be really useful for patients to give them some idea, like when is this most likely going to happen, if it's going to happen. We use it clinically, right? If we have somebody with an anti-PD-1 and they come in and we don't anticipate in the first cycle or two that they're going to have trouble with their liver. That usually doesn't come for 3-6 weeks, right? We always check, but mentally that's how we think. So.
And Dr. Doolittle, in your experience, have you found that, that, again, because we know that things do tend to happen early, but, I have found that I think patients feel shocked if they get an IR, a later immune-related adverse event. And I think all of us, even I can admit, I think I'm maybe a little bit less vigilant sometimes when it's really getting on in time. Mm-hmm. I don't know if you've had any different experiences or any advice. It's just something that I find is a little hard to kind of stay vigilant in a way.
Yeah, absolutely. I think a lot of it is I know most on the call that take care of these patients are really careful about this, but we really hammer home If you have symptoms, let us know. If you think it has nothing to do with immunotherapy, let us know. If it is on the sheets we give you, let us know. If you have symptoms and it's colitis and you know it's colitis and you're holding on because you're afraid we won't retreat, if we don't know that you have it, you can make things so much worse. If we know, when we know quickly, we can move in quickly, dampen the side effects, and try to continue your therapy. If we wait until your colitis is so bad, you have a gut perforation, then that shuts us down indefinitely. So more is better in our culture. People want more treatment. They want a bigger house. They want a bigger car, they want more Yervoy. Intuitively, it seems like if 10 of Yervoy will help you feel better, 20 will make you feel twice as good. And it just doesn't work with this. And I really do. Right. I really talk to patients about that piece.
Yeah. And, I try to use the phrase, and we'll talk some about communication. I try to use the phrase, I'm paid to be here, and I want to take the responsibility for deciding what's important. It's not your responsibility, that's mine. And so just pass on everything to me. And a lot of times you'll get reassurance from me, but if not, then we'll take action quickly, because I do think there is that pervasive fear. Are they going to take this away? Especially the other thing I find is kind of an issue is, and this is a little bit less common in melanoma right now, that patients would have had cytotoxic chemotherapy first. But I do find that if patients have had cytotoxic chemotherapy first, they know that there's a natural ebb and flow to the symptoms. For example, when I treat bladder cancer, they know, okay, they're going to feel worse for a certain period of time, then it kind of gets better. And so I think that mentality kind of can persist as well. And so I think that's tricky, because we want them to say, no, if you're tired and can't get out of bed, then that's really never okay. We don't expect, it's not normal at any point. It's tricky. I think that is a difficult challenge. And one of our wonderful advanced practice providers, Jennifer Hines, is going to be on our final session to help talk about her experience in counseling patients about some of how she tells patients about differentiating and tries to give them good anticipatory guidance for things like that with the chemo. But I wasn't sure if there were any other questions that folks have. It seems that one figure is very popular, and we'll make sure that everyone has access to that reference.
So I think, kind of building on Mary Ellen's question about, how do you educate patients the difference between, like you said, Libby, between sort of cytotoxic chemo or traditional chemo and immunotherapy. Do you feel it's really important that the patient know that there are these differences? Because unfortunately, a lot of patients think immunotherapy is just another type of chemotherapy. And so how do we reinforce that and maybe in a more simple fashion so that expectations are there, and so that, like you said, they have a better sort of communication with you about the late effects or differences they may see if they did have traditional chemotherapy? And that would be for all, you or Dr. Doolittle.
So I think one of the things, and Dr. Wolf Birchfield's experience would be different from mine, right? Because she's right. I don't have a lot of patients that are treated with chemotherapy unless they have, unless immunotherapy has failed that patient and we have to move on to something else, right? But what I do tell, it can also work against me too, because people are like, yeah, I don't want immunotherapy. My, grandmother had breast cancer and her hair was bald and she lost all this weight and she never got better. Because I also have to have the other conversation with the patient. Immunotherapy is not chemotherapy. You may not lose weight through this process. You may actually tolerate this very well. The side effects are very different. So my conversation up front is a little different that way. Most people are afraid of chemotherapy, right? Just the thought of starting chemotherapy. And so I'm in there going, or I have targeted agents. Yeah, these aren't chemotherapy. They have side effects, but they're not chemo, and trying to work through that. Dr. Wolf Birchfield, this is really more your world.
Well, and again, you have folks who do get chemotherapy, but often they're not pre-treated with chemotherapy anymore, probably. Yeah, I do, to answer Dr. Klemp's question, and Dr. Potts, one of the colleagues on this call, is doing research in this, and I'm going to put in a plug for something that she's working on in a little while. But, I do draw a distinction and essentially just tell them, we talk about a little in principle, some of the ways that things are different between them, and also the idea that, you know, the immune system can ramp itself up and kind of stay unchecked. And so as Dr. Doolittle outlined, I basically tell them that if you have anything that's severe for any period of time, I need to hear about it. And if you have anything mild or worse that lasts for more than 2 days, I have to hear about it. Because I want them to have a framework, and I tell them I will never shame them. I will never make them feel silly for asking a question. And at the best case scenario, what we're all hoping for is I offer them reassurance. So I want them to give me the opportunity to reassure them. But I just tell them, hand that over to me. It's not your job to worry about whether it's significant. I will always decide that for you. So that's kind of how I do it. But that's a great question. Well, thanks, everybody. We can get back to, I guess, the case is next, and then we have some more things. Okay, so Mrs. T. Okay, so back to Mrs. T. So she receives her first two cycles of nivolumab and ipilimumab without any significant events. Well, after cycle 3, she notifies the office of a widespread and itchy rash. And so she shows up and has an itchy skin eruption. And using this, I can't remember what this is called. I know that there is a reference for this. I should have put that there, but this is actually the way the burn unit determines body surface area that's been burned. And this is what we use in oncology too, for any of you who aren't practicing clinically. And so basically this patient has been determined to have grade 2 toxicity. And so we decide that, we try per NCCN guidelines to use topical treatments whenever possible, but for her, it kind of just doesn't cut it. So she ends up on some systemic corticosteroids and then is tapered down. And after some medical decision-making, once her rash stays quiescent, after we give her off her taper, and the decision is made to proceed with the nivolumab by itself. Next slide, please. So we'll talk a little bit about immune-related adverse event management. And the main reason is because there's no blanket way to describe it. It's just completely patient grade, location specific. And we have wonderful guidelines. So we have guidelines from SITC, the Society for Immunotherapy in Cancer, from ASCO, from NCCN. And the bottom line is early recognition is key. And as Dr. Doolittle said when he counsels his patients, he says, look, if you get severe diarrhea and end up in the hospital, we're going to have to stop. If it's mild, then let me know and we'll try to head it off at the pass so we can resume. But anyway, so there's no blanket way to really discuss it because it just depends on the unique situation. Next slide, please. So for monitoring, there are guidelines for the way that we should monitor labs. And, we have so the SITC and ASCO and NCCN do have guidelines for these parameters. How often should we measure TSH? How often should we measure creatinine, et cetera? The trouble is we don't, for things that are symptoms, there's no lab we can check. And most of the time, there's not going to be any imaging that we can check. And so in reality, the monitoring is actually clinical and based on the patient and their support persons understanding education and communication. And for the most part, symptoms that if things happen right during the visit, then we'll talk about it. But, the question sort of becomes, they spend, 20 of their 21 days not in the office. So that's a lot of responsibility for them. So the next slide, I think I start to talk a little bit about this kind of patient counseling and education piece. And I wouldn't say I have this down. As I mentioned, Dr. Potts is a researcher here at KU who's doing some research in this about patient counseling and actually has a study that she's doing, which is a very short interview-based study with clinicians who meet with patients about immunotherapy. And we'd love to hear some about what you see, how you approach counseling and the deficits. And she's also conducting other research that's with patients. But what I would say is that while there's research that shows that using electronically monitored patient-reported outcomes does improve patients' quality of life and sort of dose density of their treatment when they have advanced cancer, this isn't widely available. And in truth, it's actually not widely acceptable to patients. I was for the Alliance Cancer Research Network symptom management call recently when they were talking about trying to integrate these electronic PROs into trials and how the most common response is that patients still want to even do those on paper, even if they have the option in it, we can facilitate it for them. So we will see these, the winds of change are coming, and I do think people are getting more comfortable with a more digital life. But in reality, self-assessment and reporting is still the backbone. It really is. And so that means that we're relying on counseling patients and their support people, even though there's no guideline specific recommendations for the best way to do that, the most effective way, the way that balances education with safety. And so again, Dr. Potts is doing some of this work that'll eventually help inform our practices. But unfortunately, we know that the way that a lot of us do counsel patients isn't as effective as we want it to be. But I do have a few thoughts that I put together about different approaches that can be considered. So I do think some general principles are, now that thankfully we're through, knock on wood, what seems to be the worst of this current pandemic, it's essential whenever possible to have a caregiver, support person, spouse, friend, anybody with the patient when they're getting this information. If possible, more than one is better so that people can listen on the phone while in the visit. I do think that having multiple methods of providing this information is helpful because people learn in different ways and learn in different ways at different time points. It's helpful for them to have a reference. So giving them verbal instruction in person and written materials is helpful. Having websites or videos that you can direct them to in order that they have other ways of learning to retain this or to refresh their memory is really helpful. So I would say that, as Dr. Doolittle hinted at or said before, providing reassurance to patients that reporting them is not necessarily going to mean that we stop their treatment, or that even if it does have to stop, it won't necessarily mean it's going away. That is a key part to counseling because that's such a pervasive fear. And I really do believe myself that it can get in the way of people wanting to report things. Next slide, please. So I wanted to present to you a couple of ways that you could think about counseling patients about immunotherapy specifically. So this one that I've labeled ER approach, this is not anything that's been studied. This is the way I would consider it. So when I was in training, an ER doctor at the institution where I trained told me, our job in the ER for every patient is to rule out the three most likely things and the three most dangerous things. And so I think depending on your patient, you could think about focusing some of your discussions on some of that information, knowing that and telling them that is not the entire extent of what they could experience. But many people really do benefit from getting specific examples, right? I know most of us try to use patient language, and so saying, you could get dermatitis or pneumonitis is not helpful. And most of us would try to give some examples and say, so you could have lung inflammation, meaning that you could feel short of breath or have a cough, et cetera. So, but I think trying to look at that ER approach of what are the three most likely things and what are the three most dangerous things that you want them to look at. That's one approach that may work for some folks. And you can kind of do that. That might be a good touch up. I think when there's this great patient communication tool that's actually been pioneered in the surgical literature called Best Case, Worst Case by Dr. Schwartz. And we have all the references for you outside of the PowerPoint too, but the best case, worst case scenario involves having a diagram like this that you draw. You don't write the words or these boxes, but they say that you basically draw a star and say that's the best case. And then you draw a box on another side of the paper and say this is the worst case and draw a line between them. And then you draw like a circle or an X mark on the line and say, this is the most likely scenario, and then describe them. So the best case scenario would be that you don't have any side effects or symptoms from treatment. And we know that's statistically not that likely, but it happens sometimes. That's the best case. The worst case is that you could have severe side effects. And you could describe some of those and say the most likely scenario. And for immunotherapy, I do tell patients often that they may have one or two mild or medium effects that we need to watch for, and they sometimes need ongoing management. But this best case, worst case scenario is one way that you could think about counseling patients so that they don't feel overwhelmed thinking that their entire body is going to turn on them at any second, but also that they're vigilant. So those are just some thoughts.
Hey, Libby,
next slide, please.
Question about that.
Uh-huh.
If you go back to that thought process, which I really like, so you're basically risk stratifying using your ER approach. So I was in a meeting, I don't know, a few months ago, and someone, a nurse had asked about Jimmy Carter, and this goes into melanoma, and he's obviously an older gentleman who was treated early with immunotherapy and is still, thriving. So do you find that our older patients better candidates younger, or does it matter? Or is there kind of a risk stratifier that helps you guys predict who's a responder, not only what are their most likely risks for side effects, but who likely is going to benefit besides, using maybe some biomarkers? Like how does that age play into this, I guess?
Well, I'll say something first, and then I'll hand it over to Dr. Doolittle, who probably has some helpful, maybe more helpful thoughts than I do. But so when deciding, it sounds like what you're asking is how to decide if immunotherapy treatment might be good for someone. Is that what you mean? Or that they're more likely to have side effects?
Likely that an older person is going to be more likely to have these effects or less? I mean, is there kind of any rhyme or reason to that? Not only with response, but with the types of side effects they could have.
Well, with the diseases I treat, I don't think that age has been shown to predict necessarily for response to immunotherapy. And I wouldn't say, and I will defer to Dr. Doolittle if he has heard about data with which I'm not familiar about age related to specific effects. What I would say is that, chronological age is important, but what I would say is almost more important in my practice, who are largely older patients, since I treat prostate and bladder cancer, which happens in older adults sometimes, is kind of frailty. Do they have frail tendencies, or are they really robust? I mean, I've given nivolumab and ipilimumab to an 87-year-old who did great, and I've questioned it for a 55-year-old who's very frail. So what I would say is I do talk to patients. I don't use frail because that is sometimes referred to as the other F word in palliative care. We don't say that word because it's not a very nice word to say, but I say medically vulnerable. So sometimes I will tell patients I think they might be more likely to feel their side effects more because they're more medically vulnerable because of whatever health conditions they have. But there may be some additional answers there too.
Yeah, I would chime in too. I don't know of the data, and I'm sure they're emerging on characteristics that put a specific patient at risk. But Jen, I think they're going to emerge and not have anything to do with age.
Okay.
Because I too am like Libby. I've had octogenarians. I had a nonagenarian that I gave single agent IPI to. He is a chemist. He knew the literature better than I did by the time. When we were having an informed consent conversation, I thought he was informing me of what is a really smart guy and ready. He wanted to do it. So we did it. And he actually flew right through. I have an octogenarian patient right now that we're giving ipi-nivo to, and he's doing great. I do think there will be objective ways to know which patients are at risk. We're just not there yet. And I don't want to fall in the same category we did with chemotherapy, where in our very paternal, and I do mean paternal way, we just said, okay, you're 65, you're too old for treatment, or you're 75, we're not doing that.
And that was kind of the second part of that question is, I mean, is there this age factor that goes into that decision making? But it's good to know. And I think people see people like Jimmy Carter and they're like, wow, I could be 95 years old and get, immunotherapy, which is awesome. But I love the fact that that's real, that's not a
Now, Bob Dole is getting immunotherapy at 98 with his lung cancer. No judgment. I'm just giving information.
But again, if you know how better than it all depends on their goals of care.
It really does.
It really does. I did want to share some resources, and we have some really great information from Dr. Doolittle to come still, but about some resources here that I found in this great summary article about exactly what some of the tools are that are available to share with patients about specific side effects, about medication diaries. Well, I guess we don't have oral immunotherapy agents currently, but anyway, so there are some good resources where we have a list like this compiled about what can teach patients what or reinforce what. So as Katie has these resources compiled in our toolkit, I believe, is that right? The references, I mean. And so that the references there can lead you to this paper that has a really good outline of all sorts of different multimedia information you can share with your patient. Next slide, please. Okay, so we thought we would do a quick poll question because we want to be respectful of everyone's time. We're going to stay on time. But so are there any, in the chat box, if you can please share if there are any particular resources that you provide to patients about immunotherapy side effects and or reporting them, then please do. Oh, so Dr. Grace Martin sent it to me, I think. I think you may have sent that as a direct message. Will you share that bigger, Grace? So since Grace is she's doctor of pharmacy, but also is an oncology pharmacist. So she has these great resources that she provides patients. So she'll make sure it's in the chat visible to everyone. Thank you. If anyone has anything else that they love, then please throw it in there for sure. So while people are doing that, I'm just going to continue on. And so with Ms. T, so she continues on nivolumab, and she doesn't have any recurrence of her dermatitis. She does get some hypothyroidism, but then we're able to manage that. We hear, because she's doing so well on her treatment and she's so medically stable and her cancer's controlled, that her insurance payer is going to mandate that her treatment is transitioned into the home setting and to home infusion. And so, this is a big paradigm shift, really. And so I wanted, Dr. Doolittle has been a very brave oncologist to pilot this and has educated all of us through his experience at KU with this. So we wanted to talk some about home infusion of immunotherapy and help us all be prepared.
Great again, Libby. Yeah, I think just very generally, I'd say this is the direction all of this is going. And so we're learning to adapt quickly. I will say this, we found out the last 6 weeks of 2020 that 2 of our patients were going to start home infusion immunotherapy. And we basically had 6 weeks to try to figure out what that was going to look like. And it is really different, right? Our workflows are very carefully orchestrated in the outpatient setting, in the infusion center, in the hospital setting. So when you look at something like this, it caused a great deal of anxiety, and rightfully so. I think from a payer perspective, we're just starting to see an increase in, we will pay for the first infusion, and in our situation, the patient had a choice for home infusion or to go to the CVS infusion center. For immune checkpoint inhibitor therapy, they have let us treat once or twice. We had asked for 6 months, but we don't always get that because I think they're feeling that the actual incidence of infusion reactions is so low that it justifies being in the home. Some drugs won't lend itself to it yet, but I'm telling you, there will be a new form or a new infrastructure put in place to take care of that. So the goals of home infusion therapy, I mean, everybody, even the payers, I mean, we're all around the table, want the patient to safely receive their agents. And our big challenge, of course, is to have complete transparency among the members of the team that are going to be involved in this, including the insurance company, those that schedule, those that monitor just what the patient experience is, and then who's keeping track of the care, who's keeping track of side effects, how does this, it's changing our basic workflow, and what are we going to do with our system to make sure that a shift is done well. So we did start this piloted home immunotherapy program in November. And can we get the next slide? And I got to just be really honest with you, it's bumpy because our infusion nurses work at an office that is south of the main campus. We were, for the first time, trying to negotiate with pharma company about where the drug was actually going to be given. We didn't know what kind of timeframes would be allowed and how much lead time we needed to give them to make something like this happen. But over time, I think things have really settled down. We now have a way to actually order home infusion immunotherapy within our electronic medical record. That's huge. because the last thing in the world we want right now, with as complex as healthcare is and as complex as our own health systems are, is having, parallel programs where in this group, since they're home infusion, we're using this tool, and the in-person infusions, we're using something else. So getting this all to work within our natural workflow has been, I think, essential. The way it works now, there's a 3-day lag period between when the patient sees the physician and when the drug can get delivered to the home. The drug does get delivered to the home. There's some talk about trying to deliver it to another office within the city and having the infusion area go pick it up there. I mean, these decisions are really ongoing right now. But the model as it exists, the infusion area actually mixes up the immunotherapy in the home, establishes an IV, infuses, and then removes the IV. But in my patient situation, he was responsible for making sure that all the equipment and everything was delivered back to the cancer center. It's a little bumpy, but I think it's much better than it was when we first started. And I get to say that, I shouldn't say when we first started, when those that put a lot of time and effort in to make this happen for our patients first started. Can I have the next slide, please, too? So the idea is the patient is seen in clinic, the next cycle of home infusion medication is approved, send the prescription to the infusion therapy queue, because now there's a cadre of infusion nurses that are going out. The cancer center pharmacist double checks the treatment parameters. Then there's a signal to the home infusion company that the patient is cleared for administration. Then the home infusion company sets beyond that where date and time. Again, I think this is much better. You would not imagine, oh yes you would, you're all cancer people. Just when a patient leaves the clinic and goes upstairs for infusion therapy, there's like 10 different checks that everyone goes through before that patient is given therapy. And all of those safety checks have to be incorporated into the way we're delivering therapy into the home. Okay, the next slide. So even with the bumpy part, and it wouldn't have been if we'd had more lead time, it can work. It does work. I think home infusion is going to become the norm. I couldn't help but put this in the slides. Yeah, I remember when nurses were chemotherapy or immunotherapy certified, it wasn't considered that big a deal. Oh, it's worse than that. I mixed up chemotherapy when I was a 3rd and 4th year student. No hood, no gloves. And I'm proud to say I have 3 children. They all have 10 fingers and 10 toes. So, I mean, our times change, right? And we now have educated nurses and specialized nurses that are ultra specialized in the infusion area. And before they were set up in the infusion area, everyone said that was dangerous. All immunotherapy, all chemotherapy needs to be done in the hospital. Well, no, you can really do it outpatient just fine. You just have to build it. You have to make sure everything is part of the service so the patient safely gets treated. And arguably, at least in the outpatient setting, that was a nicer way to get your treatment than to be admitted. But at the time, it was really considered radical and dangerous. Well, this may be considered radical and dangerous now. But I really do believe that it can be done safely. We just have to be really thoughtful and careful about how we do it.
Thank you so much. I was going to ask one question about that, and then we can do this poll, but it kind of sounds like your experience is such that, once you got through the initial bumps, which were taller or bumpier because of having, you said, such a short lead time, it really has been relatively smooth. And you didn't say this specifically, but one thing that occurred to me is that it sounds like you might be sort of giving a very gentle call to action that this is coming, and it would be better for all of us that we would have these protocols before it gets thrust into your lap, because there's seemingly no way around it when we are handed this down from the payers. And so trying to work on systems to accommodate this now, even if you're not hearing that, and is probably helpful and wise. Yeah. Well, we can take another poll. So I was just going to ask of the folks who work in an oncology clinic, has anyone managed with, with at-home immunotherapy on this call yet? I was curious to hear. Well, it looks like most people are probably in my camp that I haven't experienced it yet, but I think we'll soon all be in Dr. Doolittle's camp and be pros at this. So, well, I know we, as Katie always is so good to remind us, we always want to start on time and end on time so we can take some time to our questions. Or Katie, if there are some wrap up to do, then we can do that in the last 3 minutes if we need to, and then open back up for questions.
Yeah, let's do that. And then if there's any questions, then we can get those answered real quick. So Libby's already put the plug in, actually, and Grace is on the call too, so she can plug herself even, but she's going to be our next ECHO guest speaker, and that's going to be on Friday, July 16th at noon. And that will be covering tyrosine kinase inhibitors, toxicity monitoring and management. And then Libby also mentioned Dr. Potts is doing this little sub-study, qualitative interviews for our Toqq-Rcc project. And she is looking for people who might want to take 15 to 20 minutes and visit with her and answer some questions and just have a discussion. And we will provide a little compensation for your time. So spread the word for that too. You're welcome to just send people my way and I can help get them plugged into that.
And the next session is with Grace Martin, and I will be also very generalizable to other cancers and other oral cancer agents in addition to tyrosine kinase inhibitors, because this study really is funded around kidney cancer. That's a really important therapy, but so many cancer therapies are oral now, so we'll have lots of principles that can apply more widely.
Absolutely. And this is just a reminder of your code for continuing education credits. And we can stop there and see in the last minute or so if anybody has any questions or comments. Thank you, Dr. Doolittle.
Yes, thank you so much for being here.
Thank you. Thank everyone.
This isn't a question of any sort, but this is an excitement. I mean, I've been at this for 35 plus years, and Dr. Doolittle, I can acknowledge, the times of mixing chemo with no hood as a nurse, and on evening shift. But anyway, and then, doing IVIGs in the home, when that became, a big deal, we sit there for 8 hours with the patient. So it's really encouraging to me as a oncology / palliative care nurse to see the progression of where we've come from and what we can do to help our patients and so that they can do the things that they want to do and do it in their home versus all these clinic visits. There's so many pros to these things. I know it scares us as health professionals that, they've got to be under our roof and everything. But, I think there's a lot still to be done under our roof, but I get excited about the future of where things are going with this.
I concur.
In my retirement, I can sit and watch people get their medications in their home.
That's awesome. I completely agree with you. I like the optimism, Dr. Doolittle. I think because it is a big, scary change and shift. And I do think that the optimism there that we can do this, we can make this a usable tool and make it safe for our patients. I think that for me, that was a big, honest message today. So I appreciate that. Any other questions? Are we good? I think it's time to go. So you guys enjoy the rest of your Friday. Thank you so much, Dr. Doolittle. It was good to see you.
Thank you.
We'll see you, let's see, July 16th.
Thank you, everyone.
Yes, thanks.
All right, thank you all so much.
Bye.
Bye.